So I want to give I want to answer those questions what you gave. So here are my main principles. Let's start first. I just want to put one slide. Principles of revision arthroplasty. Of course, we have to achieve a pain reduction, we have to achieve a long-term fixation, and of course we have to restore function, leg length and bone stock, and you have to always think about the next operation. So this is the first question: do I keep well-fixed component? I know sometimes it's not easy to remove well-fixed implants, but here is my answer for the first question. In a septic situation, I was mentioning already during my first talk, we have to remove all foreign materials, also well-fixed implants. During my first talk, I showed how to remove well-fixed implant during the video. In an aseptic situation, well-fixed stems, I do keep them if the stem position is acceptable and there is no damage on the taper. But well-fixed cups, I think we are working on a study right now. Isolated stem revision can increase the risk of dislocation if the cup size is small and if the patient had a previous other approach. Of course, if you have a malposition of the cup, as the previous speaker mentioned already, of course you have to remove it. But sometimes in those cases, if they have a higher risk for dislocation, I think I'm not doing isolated stem revision. I do also cup revision, maybe with a dual mobility cup, because if you have a dislocation in a very short interval, you will have you need an additional surgery, and in this part you can increase the risk of infection if you do in a short interval another revision surgery due to the dislocation. So cement or non-cement, I agree with my previous speaker. The majority of cases we are doing cementless. We are always trying to do the modular stem from the Link company. We also do the Zimmer-Wagner stem. The modular stem has of course the advantage if you have a dislocation, you can change just the proximal part and you can make bigger proximal part to adjust instead of removing the whole cement. In cases like you can see here with a severe osteolysis, in those cases we are going for cemented with impaction bone grafting, but again in the majority of cases we are doing in an aseptic situation cementless. But in a septic situation, of course, we will mix antibiotic to the cement. In those cases, of course, we are going for cemented revision. So here is a case where we are going for cemented stem. This was a case, 88-year-old. This was done in an external hospital with a cementless stem. In this patient, I think the patient is 88 years old. You are not doing a mistake if you do a cemented stem, and you can see on the intraoperative image the subsidence was not possible anymore because it stopped to the ceramic head. In this case, I revised the patient just with a normal SP2 stem. Similar cases, old patient, we heard already, if you have, I'm using a cemented stem. This was loosening with osteolysis, as you can see. In these cases, if the patient is old, you can just do cementing technique. So cement in cement revision was one of the next questions. Septic situations, never. We have to remove all infected tissue and also all foreign materials, and it also includes cement. In a aseptic situation, we heard from the previous speaker, if you have an older patient with a good cement mantle, you can do cement in cement revision. So question, trochanter osteotomy, ETO. In endoclinic, we try to avoid it. Of course, it's not always possible, but almost 99% of our patients, we are doing the endofemoral technique. I was already showing you in my first presentation how to remove. In the proximal part, to remove the cement, you need, of course, different type of osteotomes and chisels. I mentioned already. In the deeper part, you need a specific instrument. We have the specific burrs or the corkscrew, as you can see in the middle. With this corkscrew, you can remove stepwise cement. So we are trying to avoid ETO. So what about dual mobility cups? Of course, patients with a risk for dislocation, we are also going in a primary situation, like for dual mobility cup, if the patient has incompliance, alcohol abuses, We heard already from the previous speakers, dementia, epilepsy, or Parkinson, or if the patient has any spine fusion. In those cases, we are also doing a dual mobility cup in a primary situation. I think this is also in the revision cases. I was mentioning already in my previous slide, if we are really radical, and if we have to remove the proximal femur, we have to use dual mobility cups, and if you have loss of greater trochanter, you will also have a higher risk for dislocation in those patients. I also go for the dual mobility cup. So I showed this already. This is the main drawback of the one stage, maybe the main reason for failure is dislocation. Once I showed already in those cases, I do a dual mobility cup. I think if you have aseptic situation, if you just put a cemented dual mobility cup, I recognize that those patients have a higher risk for early loosening. In those cases, I do recommend to reconstruct the acetabular defect, for example, with a TM revision cup, and cement a dual mobility cup inside. I think you will have a better results with this combination. Thank you.